Terima kasih, thank you Christina. Meskipun saya sudah tinggal agak lama di Indonesia, saya tidak berani memberi pidato dalam bahasa Indonesia. So I'm going to switch to English. Maybe 30 years ago I did berani, but now I don't. So my apologies. First, let me express my thanks and appreciation to USAID, to the HP Plus project, my colleagues who worked on the health sector review, Prof. Escobar, Prof. Mewita, other colleagues. It was my privilege to come back to Indonesia this last year and review a huge amount of information that you all have collected and produced about your health system and health system performance, and to give what little advice I could to the health sector review team as they developed their report. And I was very delighted to see the final report and the policy notes from the 10 thematic papers to come out and be presented 2 weeks ago here in Jakarta, to be produced in Bahasa Indonesia by an Indonesian team. I think that was a very important step forward for the progress of health system development in Indonesia. So what I would like to do in the few minutes I have with you this morning is share with you my own personal observations that I have put together from having had the opportunity to review the work that you all have been doing and try to synthesize what I think are 5 important challenges facing Indonesia in its journey to universal health coverage. Now, these are my views. They may not accord with everyone else's views, but it's been an opportunity for me to come back to Indonesia after having lived here for many years, but most recently 30 years ago, and discover an Indonesia dramatically different from the one I knew in the 1970s and the 1980s. Now, for those of you who were also in Indonesia in the 1970s, you probably know what I'm talking about. But there are a large number of Indonesians today who were not around in the 1970s. And I'm not sure they all appreciate the changes that have taken place here, when the place where we are sitting this morning were simply open fields when I first came to Jakarta. And very little of the development of Jakarta had taken place between Kebayoran Baru and the main part of the city. So just keep that in mind. So next slide, please. So let me start just coming back to a basic question. What is universal health coverage? Because I think it's important to keep this in mind as we think about Indonesia's journey. So in 2005, the World Health Assembly passed a resolution which basically defined UHC as a state of affairs where the health needs of all of the population would be met without undue financial hardship. This is a very ambitious goal for any country in the world, and almost no country in the world, in fact, I would dare to say that no country in the world fully achieves this goal, right? Many come close, but no one fully achieves it. In 2015, WHO, especially with the development of the Sustainable Development Goals and SDG 3.8, deals with universal health coverage, modified this definition in a very important way to say that it's a state where all the essential health needs of all of the population are met without undue financial hardship. And of course, as is often the case in our international community, they didn't really define what essential health needs was very precisely. They left this to each nation to think about and to define. The key point I want to emphasize here is that both of these concepts include improving both health outcomes for the population and financial risk protection. And both of them talk about equity. They talk about reaching all the people. And these are the 3 things I think we need to keep in mind when we think about the pathway to universal health coverage. I want to point out as well that coverage, this term coverage in universal health coverage, includes 2 very different concepts. The first is health service coverage, which is the actual use of services related to need. And the second is financial coverage, which is the benefits, the financial benefits, what one might receive in response to healthcare, the healthcare expenditures. And these are 2 very different ideas. One relates to actually delivering services to those who need them. And the second relates to compensating people in some way for the financial risk that they may incur in using those services. So let's keep these two things in mind. Next one, please. So briefly, just a couple of quick points as I've observed in my opportunity to come back to Indonesia. Indonesia, in its movement to UHC, has emphasized this more comprehensive definition of UHC. And I think this is something we'll come back to, I hope, in the discussion. In terms of the period after 2015, Indonesia, in my view, is one of the major leaders in the world in the movement towards UHC. It's a very important place where UHC, the journey to UHC is being developed and worked on. It's important because it's such a large country. It's important because it's a middle income country, rapidly increasing its resources. And it's important because it's made so much progress in basic health development in the previous decades, in infertility reduction, and has a growing health systems capacity. For those of us in the international community, and for me personally with my history in Indonesia, this is a place to watch. What you are doing, the problems you are encountering, will provide lessons for the rest of the world, not only for the people of Indonesia. So I think that this is very important to have this discussion that we're going to have today in this continued conversation. Next one, please. So I want to just take a minute, I am an academic, to share with you a bit of a conceptual framework. This will be the only one that I will do. This is a framework for thinking about health systems performance that was developed by colleagues at Harvard and myself, published in a book, the lead author of which was Mark Roberts, called Getting Health Reform Right. And I used this framework in talking to the health sector review team and thinking about how to frame the conclusions of that report. And the key things I want to point out to you here is that we start on the right-hand side with thinking about the outcomes of the health system. This is the reason for the health system to exist, okay? And that is that it produces health for the population, that it produces financial risk protection, it protects people from those high costs of healthcare, and that it produces satisfaction for the citizens. Every politician knows this, that citizen satisfaction is a very important part of what is done in the health sector. And we need to think about these outcomes both in terms of the average level. We talk about infant or child mortality or life expectancy, but also about the distribution. What's the difference between the better off and the worst off, the highest and lowest in income, the geographic regions, difference between the sexes and age differences and so on. So both level and distribution are important. And this framework tells us to look at some of the things we can more easily observe: access to services, quality of services, efficiency of the system, but think about how those things impact the outcomes that we care about. And to ask questions: what is explaining the performance that we can observe and measure? What can we do to change that performance using policy and program measures that we can enact as part of public agencies? And then thinking about those things that we can change, we created this concept of these 5 health system control knobs. Now, these are not the only way to think about things one can change. WHO talks about something called the health system building blocks. But the point is, we need to align improving the performance with the measures we can take to bring about changes in that performance. And in a country as large and diverse as Indonesia, we need to think strategically, because not every problem can be easily solved, and not every difference in performance is equally important to the population. And that's really the hard job of planning and policy making, is thinking strategically. Next one, please. So I want to start with some positives, and then I want to talk about these 5 challenges that, in my view, are areas where Indonesia would benefit from thinking strategically. And many of these are captured in the health sector review report and in the discussions that have happened. So first, let's just talk about the period since 2014. One thing that really attracted me to come back to Indonesia to work with the HSR team was this tremendous progress that Indonesia made in establishing national health insurance in 2014. So what has been done? You created a unified national health insurance system. This was a very big step forward. You've significantly increased government health spending as part of that movement. You've had a dramatic increase in enrollment in your national health insurance system. Moving towards universal, you're getting close to universal enrollment. And especially those who are defined legally as poor have been given advantages in being enrolled in the system. Your data shows some significant reduction in out-of-pocket spending, and very recent results, which I only saw last week, suggest that this is even larger than the earlier data had shown. And that's a very positive thing. You've been continuing your investment in government healthcare delivery, in the delivery system, and also there's a large parallel growth in the private sector, and there's evidence of increasing access to clinical services and hospitals as a result of some of these more recent policy development. But let me now turn to these are all very positive developments, and I do want to emphasize, I want to compliment you all on the really excellent progress that is being made. That said, there are challenges, and I want to focus on 5 of them. Next one, please. So challenge number 1, there are large and increasing financial deficits occurring in national health insurance. Despite the fact that coverage has been, financial coverage has been nominally provided to most of the population, the system is running significant deficits, and this is a challenge for the future. What's the reason? And as you'll see in each of these challenges, I'm going to try to talk about both the diagnosis, what is the cause of the problem, and also what might be done. And I want to emphasize, I speak very tentatively about what might be done. This is really one person's suggestions for thinking for the future. Well, I think in terms of causes of these deficits, funds available to finance UHC, as Indonesia has defined it, with a very comprehensive benefit package in the national health insurance, I think the funds available are not sufficient to support these very ambitious goals. This is based on looking at international comparisons and the amount of money that other countries have needed to achieve coverage, real coverage, with the kinds of benefits that Indonesia has put forward for national health insurance. Also, you will find that once you expand the coverage of health insurance, there is a huge backlog of needs. People who have not been receiving services in the past, who suddenly feel they are eligible to get those services and receive the benefits, and rising demand that will follow this, along with the demand that will occur with rising incomes and education, and this will place increasing pressure on the available funds. So this is a challenge. What might be done about it? Of course, one could spend more on health. And many have recommended that Indonesia spends relatively less than other countries at similar levels of income and should spend more on health. And I would support that recommendation. But that may not be sufficient to address this challenge, because the gap between what has been promised and the resources that are likely to be available is likely to still be large. One could reconsider the comprehensiveness of the current promised benefit package. Perhaps thinking about phasing in an expanded package of benefits over time, starting with something that can actually be achieved and demonstrated and then developed over time. One could also increase contributions from different populations to help make up the financial gap. So these are the kinds of actions that might be possible to address this challenge. I recognize, of course, that there are big political issues involved in a challenge like this, but the challenge will not disappear if it is ignored. It is likely to continue and be present in the future. Can Indonesia afford much more spending on health? Yes, I think it can. Can it afford, at its current likely level of income and other demands of development, to achieve fully comprehensive UHC for everyone in the population? I think those years are still in front of us, and it will take some time to get to that place. Next one, please. Challenge number 2. We see some evidence of stalling progress in meeting population health priorities, and this is very concerning. Now, the evidence that we have is not great on this, but it is worrying, and I think it does need attention. And I think if you look at the report, the Health Sector Review report, there's a lot of emphasis on these questions going forward. So what are some of the causes? Well, one of them is that JKN's development has emphasized providing financial risk protection through coverage of clinical services. Here is that trade-off I was talking about between financial risk protection and population health improvement. Both of these outcomes are important to the population, but there is a risk, especially a risk when resources are not sufficient, that one will devote more energy to providing the financial risk protection, and that this will slow down progress in population health improvement. And I pose this as a question for you to think about how to manage that risk. In practice, this focus on financial risk protection, paying for the cost of clinical services explicitly, has created both supply and demand side disincentives at the margin. What I mean by at the margin is that JKN adds funding to an existing public system that is funded through budgets and the normal process of government expenditure. So actors in the system respond to this funding at the margin more than they might respond to the existing amount in budgets and so on, because they're accustomed to that. This is something new, right? And this is creating both supply and demand side incentives, both for the providers as well as for the population, disincentives, to maintain the priority population health programs and to favor clinical services. So things like immunization, disease control, maternal health, non-communicable disease prevention, these are things that may be getting less emphasis as the system is growing. And this needs attention in the future if population health is going to continue to improve. It's particularly important because the future costs of illness will be much greater if the opportunities for prevention are not achieved in the shorter term. So we will create further pressures on the finances of the system if the needs for population health improvement are not fully optimized. What could be done? Possibly re-examine the balance in goals between population health and financial risk protection using evidence. Think about the design of coverage in public programs and health insurance. We need to think about the politics. Citizens may be very happy with increased financial risk protection, may not fully value the benefits of population health improvement, which seem very abstract and not immediately of benefit to them. So there's a political, a communications agenda here as well. And we may need to strengthen investments and incentives to protect population health interventions. And I think the plan, the draft plan that was just shared with us for the next 5-year plan gives a lot of emphasis to these kinds of investments in the future. Next one, please. Challenge number 3, are there significant and are there increasing inequalities in the benefits from the universal health coverage programs? Now, I put a question mark after increasing because I don't think we have the evidence to fully answer this question, but it is a challenge and it is worrying. What might be causing this? Well, first of all, Indonesia, as you all know, has a very challenging geography. You have much of your population concentrated in a few places, and then you have a third of your population or more spread out over very distant and hard to reach places in some cases. And this results in strong differentials in access to services and in the supply side of healthcare. This is part of the environment in which you have to work. But what is concerning is that at the margin, this health insurance funding, because it's funding clinical services and especially hospital services, may be sending more money to where that supply and demand can be realized. And those are in the more concentrated areas of the country. So it's possible, and I put this forward as a hypothesis, not as a fact, because I don't think we have the data fully to know what's going on. But there is a risk that the current system as it is designed might actually send more money to the better off parts of the country where services are available, and might actually not be increasing the investments and the spending in the more remote parts of the country where the needs might be greater and not being met. What could one do about that? Well, first, one might consider developing benchmarks for a core package of services, something that you might define as those priority or essential services, And they might be different. These benchmarks might be different for different regions, depending on what's feasible, and channel investments and service funds to assure that those minimal levels of service coverage and financial protection are met first before channeling funds for other things. One might even think about designing region or area-specific plans combining government and JKN spending, which would be developed to try to achieve that core package of benefits in different parts of the country. So some explicit policies to consider these regional differences and equity differences, and to counterbalance what might be the trends built into the system as it is currently designed to exacerbate inequality. The next one, please. Challenge number 4. Insufficient use of the power of healthcare financing, specifically financial incentives to improve system performance. So this is, to me, the most difficult one of my 5 challenges, and that's why I did keep it as a last one, so I could come back to something a little bit easier at the end. Thinking about the causes, and much of this work was discussed as part of the health sector review development. You have a very complex system of financing flows paying for healthcare services. You have multiple sources of budgetary flows that flow from the national level to province to district, in addition to the health insurance flows of funding. And this makes it difficult to develop clear patterns of incentives, because these different financing flows each come with their own history, their own rules, and their own governance structures. Similarly, you have relatively weak governance mechanisms to strategically direct that financing and purchasing in a highly decentralized system. Now, this came out of much of the discussion we had during the health sector review meetings. And what I mean by this is that, as far as I understand it, the legal obligations between the Ministry of Finance, the JKN, and the Social Health Insurance Agency, and the Ministry of Health, while they may be defined in normative ways, in pro forma ways, in practice, the way those things are actually working is not entirely clear and not enabling some of the obligations of these different parties to be enforced or applied on the other parties. In addition, you have this experience, this radical decentralization since the time when I was here, that has given a great deal of authority to the district level. And they often have the authority to do things that they want to do in ways they want to do them, regardless of what instructions or rules might be issued by higher levels of government. So this makes it very difficult to design and implement effective financial incentives in the health system. JKN is the most flexible purchaser because it's at least purchasing something in terms of services, but it only is still a relatively small part of the total government health financing, less than 20%. So you can imagine that it is not easy to drive substantial change with only a small part of the total financing. So what to do? And as I said, this is the hardest one. One idea might be review the different complex government funding sources and find ways to simplify them in some way for health. A second idea might be strengthen the government role and direction in that funding through governance reforms, management explicitly for population health priorities, and this might come more from the Ministry of Health in terms of its role in setting norms and standards for healthcare delivery. And perhaps another way to go would be to strengthen JKN's role in these incentives, including more explicit purchasing for population health priorities in the JKN benefits model. Now, these are somewhat contradictory ideas. In other words, strengthen the governance through the Ministry of Health, strengthen the purchasing role of JKN through the health insurance mechanism. And I confess I don't have a clear idea right now which is the most feasible way to go. But I do think that this is the kind of challenge that one needs to try to address in the future in order to get the full benefits from the health financing that's being developed. Finally, it's important to think about strengthening the district level capacity and the incentives in districts to use the financing that's being provided to the districts more effectively for the UHC goals. So that's my fourth challenge. One more to go. Next one, please. This one's a little easier. Challenge number 5, and this is where I put my academic hat back on. Getting more and using more of data and evidence for policy and program improvement. And this is an set of observations that I've made coming back to Indonesia after many years. Today in Indonesia, you have very substantial, and I would call it ample, technical competence for the analytics that you need for health system improvement amongst your experts in Indonesia. I want to share a little story with you about a book that's coming out in a couple of months about health systems development in East Asian countries, China, Taiwan, Japan, and Korea. 4 volumes of studies being edited by a professor, a Chinese professor. What I found most wonderful about this collection is that every chapter in the collection was written by an Asian expert from the countries that were being discussed. So this to me is an example of the fact that in Indonesia today, you do have the expertise in your experts to do the work that is needed. But that expertise has not been used, in my view, as effectively as it needs to be for setting strategic direction for the system. The governance for this strategic direction is fragmented, as I mentioned, and there are many different actors and many different experts produce work, but it's hard to see how this gets adopted and synthesized effectively in setting the direction for the future. And then I'm going to apologize to my sponsors for this visit, but I think you're relying too much on external partners. I think you're relying too much on external partners to fund this work and to set the priorities for this work. And I'm here as an example of some of that reliance, but I think that Indonesia has now embarked on a journey to UHC, which will be very costly for you and which will determine the future of your health system. And I would like to see Indonesia play a more strong role in directing and paying for the expertise that is needed to do the work for your future. There are many gaps in evidence, and I just would list a couple of them that came out in our review. We don't know very well why population health initiatives might be faltering. The evidence is still very new and anecdotal, preliminary. We don't know much about the financial risk protection itself, who is suffering from impoverishment due to health expenditures. We monitor things like out-of-pocket spending, but that's an indicator that's very crudely related to health-related impoverishment. And I think we need to know more who is suffering from this, what kinds of conditions are causing this health-related impoverishment, and how existing programs of coverage are or are not addressing those needs. JKN, as I mentioned, faces significant financial challenges. Much more could be done in developing well-developed financial and actuarial projections for the planning of that system, and more evidence to set health and financial risk protection priorities. So what can be done? I think government itself should pay for much more of this analytical work than it has been in the past, and it should steer external partners in a strategic way to do that. Perhaps creation of some kind of high-level independent health systems policy analysis and research think tank would be a good idea. Not easy to do with all the stakeholders involved in the system, but in countries that have experienced this kind of reform in the past, and I think of 2 that spring to mind, Mexico and Thailand, both middle-income countries, they have benefited immensely from high-level and fairly independent institutional capacity for policy analysis and analytical work, and align the support of the development partners to develop and sustain this capacity. This should be an important element of future development partner support for Indonesia. So, next one, please, my last one. Thanks for your attention. There are many things that need to be done, and it is important to have a manageable set of strategic priorities. I've mentioned 5. We call them the 5 challenges. Maybe we should call them pancha tantangan. These may not be the ones that come up in your list, but I would say that one should try to avoid having too many specific types of action without a clear set of what those strategic priorities are. And the priorities should be determined in terms of the ultimate outcomes that every country cares about: health improvement, financial risk protection, and equity, and how policy and program development will change the intermediate factors of access, quality, and efficiency to achieve those goals. Finally, your journey to UHC is going to be much longer than a 5-year plan. And it's important to have a 5-year plan. It's important to have a 20-year plan. But every country, Indonesia included, is in this challenge for the duration. I mean, this is part of the challenge of modern life, to deliver these benefits to the citizens of a country. And you need to invest in your national capacities to help you get there. So terima kasih banyak, and let others share their views with us today.